Is it?
Hello. Hello, can you hear us? Can anyone confirm?
Yes, ma'am.
Okay. Sorry, there's a technical error in the speakers. We'll begin again.
A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 20th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of National Institute of Tuberculosis and Respiratory Diseases, I extend a very warm welcome to our esteemed Deputy Director General TB Central TB Division, Professor Urvashi B. Singh and her team. I also extend my heartfelt welcome to the directors and representatives from NIRT, NTI, state TB officers and directors of STDCs, esteemed faculty members from medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Now, please let me introduce the faculty from NITRD. I am Dr. Dhulika Dhingra, Specialist Pediatrics at NITRD, and I will be moderating today's session. And with me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and also former director of NITRD. To my extreme right is Dr. Alok Yadav, CMO, NFSG, and pediatrician at NITRD. I would now request Dr. Sangeeta Sharma ma'am to please address the gathering and also welcome DDG ma'am, Professor Urvashi B. Singh. Over to you, ma'am.
Thanks, Dulika. So we are back again on a monthly pediatric TB session. Today's case is another very interesting case where we'll learn how to go about with the investigations. So I'll also request our DDG TB, Dr. Professor Urvashi Singh, to say a few words. Dr. Urvashi?
Good afternoon, Dr. Sangeeta. Good afternoon, all the experts, all the team, the National TB Elimination Program family members, if I may call them, who have cared to join us, those who are eager to learn more. This effort by NITRD, which has been on for several years, and thanks to the legacy that NITRD team has been able to develop under the able leadership of previous directors, under the leadership of the current director, is an effort towards the continuing medical education of our fraternity to deal with difficult cases carefully. Now, every time they spend, an effort to find a case that will not only interest more and more medical fraternity, but also something which is a challenge for treatment and where one should be vigilant, what corrective action needs to be taken, what more needs to be done in similar cases is what they bring out for everybody's enhancement of experience, knowledge, and for us, it is a major effort as part of the National TB Elimination Program, NITRD being our own institute, because this, encompasses difficult cases and, discussing on such a platform oversimplifies and sends a clear message along that whether difficult to treat, whether difficult to diagnose, we are all in it together. We will work together to overcome any challenge that we find. This further strengthens our resolve to continue to improve our diagnostic capabilities under the program, our treatment efforts, and bringing in changes. Kindly mute your mics. So this effort further strengthens the NTEP resolve and the reach And I'm thankful to those who have cared to join today in understanding why this child Dr. Sangeeta is discussing today kept on coming back again and again with the same drug-sensitive TB. Let us hear from the team who's presenting today, and thank you, Dr. Sangeeta, Director NITRD, for continuing this effort. And all of us can pitch in our thoughts later as well. Thank you.
Thank you, ma'am. Without any further delay, we would now start today's session. Today's presenting team is Department of Pediatrics, AIIMS, Jodhpur, led by Dr. Jagdish Goyal, Professor Pediatrics, and Dr. Praveen Kumar, Additional Professor, Department of Pediatrics, AIIMS, Jodhpur. And the case presenter for today is Dr. Satya Srivastav, DM Resident, Department of Pediatrics. Before we start today's session, today's case, I would request everyone to please take up the pre-test questionnaire, which has the link for which has been uploaded in the chat box. Over to you, Dr. Satya. You can now share your screen and upload your presentation. Dr. Satya?
Hello, ma'am. Am I audible?
Yes, yes. Yes, Dr. Satya.
Yeah, and I hope my slides are visible.
Yeah, your slides are visible. Yeah. But there is an echo in your voice. If you have logged in through two devices, I think you can do that from one device.
Okay, ma'am. So I think
There is still
I have logged in through one device only.
There must be some other device in vicinity because it's causing echo.
Currently, there is no other device, ma'am. So I'm not aware why it is coming, but I'll just check again.
What about Dr. Jagdish? Is he in the same room?
No, ma'am. They're all in different rooms.
log out.
Can I stop sharing and try it again?
I see. I think you need to do that, Anna.
Yeah. You can log out and try again.
Is there still an echo?
Yes, yes.
So there's no other device which is logged in from the same room, sir? It's just your device?
No, it's just my device, ma'am. There is no other device.
There's still a lot of echo from your side. You can try logging out and logging in again.
Yes, ma'am. Just give me a minute. I'll do that.
Yes, yes, please.
In the meantime, I think we can all attempt the pre-test questionnaire. The link has been uploaded in the chat box.
Is there an echo now?
No, Dr. Satya, now it is okay, fine.
So can I share my slides?
Yes, yes, please.
I hope my slides are visible now.
Yes, yes, Dr. Satya.
And my view is clear. Yes.
Yes,
And
absolutely.
slides are moving also.
Yes.
Sure. Okay.
Please go ahead.
So good afternoon. As part of the TB Echo Clinic today, we will be discussing a case, and the title is Cycles of Recurrence When Recovery is in the End. So we have with us a patient, Miss K, who is 16-year-old female, and she was a resident of Bikaner, and she had come to us. The information given was by self and by father, and she presented to us with complaints of recurrent episodes of cough and fever with weight loss for the last 3 years, and dyspnea on exertions for the last 1 year. So initially, her cough at the beginning of illness was insidious onset, was non-spasmodic, non-paroxysmal cough, and it was productive, minimal quantity, only less than half cup per day. The sputum was yellowish in color, and there was no diagonal or postural variation. This cough was associated with fever, which was insidious onset, low-grade fever with evening rise of temperature and relieved transiently by medication. Along with fever and cough, she also had history of associated weight loss and loss of appetite, which improved on medication that she received on oral basis. Currently, the cough is worsening over the last 1 month, and it is productive cough with more than half cup per day, and it is yellowish in color, non-foul smelling, no blood and sputum, and this cough is also increased on lying down and more during early morning time. She also had dyspnea on exertion since the last 1 year, which initially she noticed while playing with peers, and that progressed to breathlessness on walking 100 meters currently, which is MMRC grade 3. She also had easy fatiguability in the form of she tires easily on doing regular activities since the last 6 months. And over the last 2 months, the child also complained of chest pain, specifically in the left mammary region, which she said was increased on exertion. There was no history of orthopnea, PND, or pedal edema, no history of palpitations, syncopal attacks, no history of recurrent skin abscesses, deep-seated abscesses, ear discharge, or oral thrush. There is no history of blood transfusion, no history of any otorrhea, rhinorrhea, greasy, oily stools, and no history of any skin rash, photosensitivity, oral ulcers, hematuria, and also no history of recurrent vomiting, regurgitation of feeds. So coming to her past history, in June 2020, she had her first episode of fever and cough, and which lasted more than 2 weeks. And at that time, TB workup was done, which showed MAN2 positive, and also sputum showed AFB positive, and CPNAT showed MTB detected with RIF resistance was not detected. And for that, X-ray was done, which showed a right upper zone opacity with associated mediastinal lymphadenopathy, and she was started on drug-sensitive regimen for 6 months. And at the end of 6 months in December 2020, repeat X-ray was done, which showed persistence of the same radiological opacities. 2 months after completing the initial 6 months ATT regimen, she again developed fever and cough with weight loss and loss of appetite. And this time again, TB workup was done, which showed sputum AV positive, and CPNAT was showed MTB detected with no RIF resistance was not detected. She was again started on 6 months course of drug-sensitive ATT regimen, but at the end of 6 months, the follow-up screening was done, and sputum AV was still positive, and CPNAT was also done, which showed MTB detected. And so at that time, ATT was continued in the local DOT center for another 2 months. At the end of the 1 month of continuation therapy, the sputum AV was done, which was negative. And at the end of 8 months of therapy, this was the chest X-ray, which showed resolution of right upper zone opacities, but there was still left upper and mid zone retrocardiac opacities, but hydraulic lymphadenopathy was there. Again, 1 month after completing the second regimen of ATT, she again developed fever and weight loss with cough, and this time X-ray done, which showed progression of the left upper and mid zone, lower zone opacities. And again, TB workup was done, which showed MTB detected with resistance was not detected, and she was started on 6 months again drug-sensitive regimen only at the local DOT center. And at the end of, she completed 6 months with good adherence and also taking drugs from DOTs only. And at the end of 6 months, a repeat X-ray was done, which showed some progression of opacities in the left upper and mid zone, and no clearance of the previous opacities. Finally, after 4 to 5 months of the third time she took ATT, again she developed fever, cough, and weight loss. And TB workup was again positive, so she was restarted on ATT. 2 months into follow-up, the fever subsided, but the cough was worsening and there was no weight gain. So X-ray was done, which showed progression of radiological opacities with now left hemithorax showing low, reduced lung volume. And first-line LPA was done, which did not show any rifampicin or isoniazid resistance. So she was continued on the same treatment, and she completed 6 months of ATT. And at the end of 6 months, the fourth time, the X-ray was repeated again, which showed progression of radiological opacities with low lung volume on the left hemithorax, and also some airway-directed structures on the right side, upper and paracardiac region. At this time, because of poor persistent cough and poor weight gain and recurrent symptoms, she was referred to AIMS in the November of 2023, September 2023. Over to the other history, her antenatal birth history was insignificant. However, she was unimmunized for age, Developmental history was adequate for age, and she was in 12th grade with average scholastic performance. Diet history was not significant. Family history, there was no history of similar illnesses in the family members, and she belonged to a lower middle class by modified Kupsamic classification. On examination, she had pallor and there was clubbing grade 2. There was no intracyanosis, lymphadenopathy, or edema. Vitals were stable with anthropometry also was within centiles, and head to toe examination was normal. Coming to respiratory system examination, upper respiratory tract was normal, ENT, and inspection on inspection of the chest wall, it was normal shape with bilateral hemithorax was symmetrical, but there was reduced chest movement on the left side. However, there was no other deformities, no scar sinuses, fistula, no engorged visible veins, and even the back interscapular distance was equal. There was no winging or drooping of shoulder spinal deformities. On palpation, trachea was midline. There was reduced movement of the left hemithorax, and the apex beat was shifted laterally. Fifth intercostal space lateral to mid-clavicular line. There was no chest wall tenderness. On further lung examination with percussion and auscultation, there was equal entry on both sides. But on percussion, there was dull note on left side in the infraaxillary, interscapular, and infrascapular region on the left side. And the same sides, there was also increased tactile fragmentus and vocal resonance, and bronchial breath sounds were there, and repetitions were also audible on the same sides. Other systems, CVS, abdomen, and CNS were normal. There was no other abnormality. So to summarize, we have a 16-year-old girl who is developmentally normal and unimmunized for age, with history of recurrent tuberculosis, which is microbiologically confirmed, with clinical improvement on treatment, but now presented with fever, cough, and weight loss with exertional dyspnea since last 1 year. On examination, pallor and grade 2 clubbing was present with reduced chest wall movement on left side, with increased vocal fragmentus, vocal resonance, dull notes with bronchial breath sounds and crackles on left infraaxillary, interscapular, and infrascapular areas. So keeping this history and examination, the possibilities we had kept in mind when the child presented to us were recurrent tuberculosis, either due to drug-resistant tuberculosis or some sort of inborn error of immunity like MSMD. And the points in favor for drug-resistant tuberculosis were recurrent microbiologically positive pulmonary tuberculosis and history of multiple previous treatment with ATT. However, there was no contact with DRTB case or no history of death due to TB in family, and the rifampicin resistance was not detected in any of the previous reports, and she improved with treatment every time. Other possibility we kept for recurrent tuberculosis was inborn error of immunity, probable MSMD, because of the same reasons, but there was no history of any other site infections and no history of any severe viral infections for there. A third possibility we had kept was post-TB sequelae bronchiectasis with exacerbation because she had recurrent tuberculosis BTT and with increased productive cough, fever, and dyspnea on exertion currently. But points against were recurrent smear positivity with response every time. Keeping these possibilities, we went for further workup, and the first workup we had done was chest X-ray. Chest X-ray done was similar to the last X-ray that she presented to us with. There was a low lung volume on the left hemithorax with heterogeneous opacities in left upper, mid, and lower zone with mediastinal shift towards left side. Costophrenic cardiophrenic angle on the left side is also obscured. And there was right paracardiac region, dilated airway structures could be seen, with some lymphadenopathy also in right side. This was a CT done. She had presented to us with the CT already done outside, and this is outside CT. And CT done was showing confirmed X-ray findings. There was low lung volume in the left side with extensive areas of collapse consolidation on the left side with probable destroyed lung on the left side with some herniation of right lung towards the left side and also some consolidation changes on the right lung as well. The other investigations that were done preliminary were hemoglobin was 8.6 and other basic investigations like LFT, RFT were normal. However, there was a reversal of albumin globulin ratio and globulin was higher than albumin. And inflammatory markers like ESR and CRP were also elevated. To look for any underlying conditions of immunodeficiency acquired. So HIV was done non-reactive and HbA1c also was within normal limits. Her ultrasound abdomen to look for any disseminated TB was also predominantly normal. However, there was some minimal left-sided pleural effusion was detected on the ultrasound abdomen. So we did a TB workup again, and sputum AFB showed smear positivity And sputum CBNet also was done, showed MTB detected, with rifampicin resistance was not detected. And a culture was sent, which we got the report later, but in that culture there was AFB was positive and MPT64 antigen was positive, which was highly specific for microbacterial tuberculosis complex. So our diagnosis at that time was recurrent pulmonary tuberculosis with current active pulmonary tuberculosis, microbiologically confirmed, MTB detected, rifampicin resistance was not detected, with TB sequelae, bronchiectasis destroyed left lung, with nutritional anemia, and to rule out drug-resistant tuberculosis or any inborn error of immunity, for the possibility, keeping the possibility of recurrent tuberculosis. So she was started on drug-sensitive regimen in September 23 when she had come to us, with 2 HRZD and 4 HRE. And paradoxin weight at the start of ATT was 46 kgs. And contact staining was done. Siblings and 2 siblings and her parents were also screened, and their X-ray was normal, and MAN2 also was negative in siblings. So as for the recurrent TB workup, because she had one of the epidemiological markers for drug-resistant TB, which is disease recurrence after previous treatment. So keeping in possibility of drug resistance TB, which could not be picked up with the programmatic CBNet. So we sent a Mycobacterium whole genome sequencing to look for any other mutations that could be present in the Mycobacterial isolates. And to also keeping in mind any underlying immunodeficiency state, we sent the whole exome sequencing of the patient DNA to look for any mutations. So after starting ATT, the fever resolved in 2 weeks, but the productive cough was persistent and weight gain was minimal, only 200 grams. We had got the first line LPA HNR report had come, and both isoniazid and rifampicin were sensitive as per first line LPA. Meanwhile, 3 weeks after starting ATT, the microbacterial next gen whole genome sequencing report had come, which showed positive for mycobacterium tuberculosis growth. And the genes that were screened were RPOB, MPT64, and HSP65, which are highly specific for Mycobacterium tuberculosis complex. And the read depth was high, which showed accuracy, and gene coverage was also full. That means the whole genome was sequenced and mutations were found. And the final report given was the multi-drug resistant tuberculosis, where there was resistance of high confidence to rifampicin, resistance of moderate confidence to first-line drugs like isoniazid, ethambutol, along with ethionamide. So this was the resistance pattern detected. And as we can see in the first picture, INHA gene, RPO, CATG, INHA, RV3169, and ethambutol B, EMBB genes were resistance was found. And with high allele frequency, which means that most of the alleles, sequenced alleles were having this mutation. And also there was a mutation to ethambutol and ethionamide also. So the final resistance pattern was rifampicin, RPO gene, isoniazid, INHA, and CATG mutations were seen, pyrazinamide, ethambutol, and ethionamide genes. And so because she fell into the, as per the DRTB algorithm, she fell into the rifampicin resistant detected group. And because there was presence of both CATG and INHA mutation, she fit into the category for receiving longer oral MDR regimen. So our working diagnosis, recurrent tuberculosis, microbiologically confirmed with MDR-TB confirmed by genome sequencing, and established bronchiectasis with destroyed lung, secondary to TB sequelae. Our report for immunodeficiency had not yet come at that time, so we still kept the possibility and inborn errors of immunity for recurrent tuberculosis. So she was started on longer oral bedaquiline-based regimen for 18 months. She received bedaquiline for 6 months, and levofloxacin, linezolid, cycloserine, and clofazimine was also started. And this regimen was started from October 23. Meanwhile, our whole exome sequencing of patient DNA had come. There was no pathogenic variant, so possibility of underlying immunodeficiency was ruled out. 2 months after starting ATT with longer regimen, there was no further fever episodes, but increased productive cough was there for 2 weeks, and there was post-acid vomiting with poor weight gain. So an X-ray was repeated and seen, which showed similar radiological picture as while starting ATT. So considering possibility of bronchiectasis exacerbation, we gave a possibility, treated her with oral antibiotic for 2 weeks. Following, there was improvement of her cough. So on follow-up, further follow-up was done at local TB nodal center, and she received treatment from DOT center with adherence to therapy. She was followed up every 3 to 6 monthly at AIMS, and 6 months from here, as we got the report from her, showed AFP negative, so bedaquiline was stopped and other drugs were continued. There was clinical improvement in the form of symptom resolution and weight gain, and she completed 18 months of ATT in June 2025. So her weight gain was significant. At start of ATT was 46, and at completion of ATT was 62 kgs. She did have symptoms of occasional cough. So this was her PFT after she completed 6 months of ATT, which showed a restrictive defect. Her predicted values were below the lower limit of normal significantly. And this was the PFT done when she completed 18 months of ATT, which showed similar picture only. There was not much improvement. There is still a restrictive lung defect. This was her X-ray when she started ATT, and current X-ray done at the end of ATT was on the right side. It showed some resolution of the obesity on the left upper zone, but there is still low lung volume on left side with venous timing shift and possible collapse consolidation with destroyed lung on the left side. Shall I go ahead with discussion?
Any questions, any queries that you may be having? We can, about the case, we can discuss right now, or else we can go ahead.
Dr. Dhulika, Kamal this side.
Yes, sir. Yes, sir, Dr. Kamal. Yes, Dr. Kamal.
So, very nicely presented case. I just two things in my mind. If a patient is being followed up in our program and he gets an antitubercular therapy second time and a third time, we would usually expect to have some MGT reports. You know, we all know that CB-NATs, even after completion of therapy, in a child who has clinically responded, may throw up surprises. But without an MG, we will never be sure that it's dead bacilli or what it is. So it was very interesting that twice ATT was started, but we did not have an MG report from our system, which was important. If suppose we did not have this whole exome sequencing report, usually what we see is sequelae like bronchiectasis. If you have not advised things like physiotherapy, they will continue to have infection in that damaged lung, which will manifest as fever, as productive cough, and all those manifestations. But to be very sure of TB, it is at times difficult. Now, I'm not very sure that how valid this whole exome report would be, because this whole exome, these genetics are still evolving. By what we see here, it looks, yes, there was a resistance, but for our program to completely miss all those resistances is a bit surprising to me. So this is what I had in mind. Thank you.
Yes, sir.
Kamal, I think you've raised a very pertinent issue. Now the thing is the very diagnosis, whether it is recurrent tuberculosis or it is failure. Because even at the end of the first course of treatment, I don't see the report of sputum smear or culture, which need to be done before you label the child as cured or treatment completed. So the final outcome of all the courses, I feel needs to be looked into, whether it is actually recurrent TB or it is failure of and that the child did not convert at all, or the child failed the regimen. So in any case, in both the cases, whatever is the scenario, because the definitions, they are different. Recurrent TB means relapse. That means your patient, your case needs to convert, and then there is reversion. Conversion, the final outcome declared cured, only then you can label as relapse or recurrent TB. So in this case, because the final outcome in any of the settings is not there, it's not been shared. So a better diagnosis would be that the child was failing the regimen. And the other issue is whenever the child fails the regimen, there are few things which need to be taken into account. One is you need to look at blood sugar, you need to look at HIV status, and also most important is compliance, the drug dosages as per the body weight, And the other thing is, once all these things they have been taken care, the MGIT, DST, the first line and the second line LPA, then because this child was not improving at all. And once it was showing that again it showed MTB detected rift sensitive. In that case, with the sputum smear positive, the first line LPA should have been sent right at the beginning of the second course, which was not sent. And also the MGIT, because the MGIT, DST, first line, second line LPA is done after the culture report, and also the phenotypic DST. All you seriously targeted or whole genome sequencing is not required, and we have MGIT which is available under the program. And you can do, after the culture, you can do the first line, second line DST, which can tell us about the rifampicin, INH, then also second line LPA about the fluoroquinolones, second line injectables, though we are not using now, and also the detailed DST. So all these, they are available under the program. I think because the system is automated, and usually it is known that the reflexly it is sent to the intermediate reference lab, and then further it goes for all these investigations. So I think one thing is that you need to retrieve those reports. I'm sure they must have been sent because this is an enrolled patient under the program. So the MGIT report should have been available, but obviously maybe it is not the detailed DST, because if the clinician has not written detailed DST, then obviously it would not have been done. And the other thing is, when your patient, you are seeing that it is rifampicin sensitive, it could be INH resistance, which was, I think, would have been known by the first line LPA, which was not done, or even TDM levels, because your patient is not improving, so the drug levels, maybe I don't see the drug levels were done anything. So these are the few things which I think they are good learning points from this case, and we need to carry forward our discussion. So any questions we need to take on?
Dr. Sangeeta, just a brief comment. It's a very
Yes,
nice
please.
presentation.
Yeah.
But I think the diagnosis in the beginning, as you pointed out, tuberculosis, because that's an obsolete term. And another important point when
Tuberculosis is the term which is actually now used. Relapse is a term which is no longer used. You're saying it opposite.
Okay,
Yeah.
but
So
probably
this does not qualify as
girl should have
relapse.
been investigated for reinfection also, because all the household contacts, they were investigated once she reached the aims. So if I'm treating at a patient and she is getting again and again, that all household contacts should have been worked up in the first or second go. That one, because sometimes there are reports also, large series from China, where good number of patients has presented with the reinfection also. So I think that is one point which when we get this sort of patient, now we have not seen such type of patient. This is what my first time I'm learning about this, but that should remain one of the area to be investigated.
Yeah. So the diagnosis would be that the child failed the regimen, not recurrent tuberculosis. Because to label as recurrent tuberculosis, you need to have the diagnosis of cured, which was not here in any of the scenarios. But the management obviously would be the same. एक ही चीज मैं बोलूंगी, इतना टाइम नहीं लगना चाहिए था. That the child, it almost took like 2 or 3 years. 3 years. 3 years with a destroyed lung. But there is no fault of yours. AIMS have done an excellent job. But under the program, it took 3 years for this child, and the child finally landed up with a destroyed lung. So the left lung is bronchiectatic changes, and it is destroyed, loss of volume. So initially, what we started was, had the first course been adequately monitored, that means do a sputum smear at the end of intensive phase, and then at the end of continuation phase, that is at 6 months, either smear with or without culture, and one report in between. So this is what the monitoring is for the first line course, which I don't see was done, or the reports are not available. So any
One
other
more
questions?
point. One more point, if I
Ma'am, I
can
have
raise
three
one.
issues.
Hello, Dr. Kamal this side. Can I raise one more point, ma'am?
Yeah.
So, ma'am, what I feel is that this thing is painting not a very good picture of our program, because it is very unlikely that 3 times, and it's a long period in between, he has been well. Had it been a drug resistant to begin with, to say that he responded at 6 months and he remained well for some time, then he again responded. And as you said, there were AFB smear was positive at times. So one thing is for sure, that it is not the fault of the presenting team, because it has all happened before the patient came to them.
Yes, yes.
But the patient, if was with us, so probably we should look at introspect and look at the records again, that where did we go wrong, because we should have had LPAs and all those things in a child who has a smear AFB positive.
Yeah,
Thank you.
actually, what we advocate about the program is that any sample which is sent, initially this NAT is done, and the second half of the sample or the second sample is inadvertently automatically sent to the higher intermediate reference lab, where they do the smear. If the smear is positive, immediately the first line LPA is done for ampicillin sensitive cases, and second line LPA for RIF resistance cases, and MGIT also. So this is what is being advocated and what is inherent into the program. So this is what I was telling the AIMS team, that they need to look into the reports under the NICSHE, because this child was already enrolled in the NICSHE. So whoever was treating, there are lessons to be learned, for that person. That there has been, probably the reports, they were not retrieved or the sample was not sent. दो ही चीजें हो सकती हैं, तो सैंपल ही नहीं भेजा गया ऊपर इंटरमीडिएट रेफरेंस लैब को, अगर भेजा तो उसकी रिपोर्टें नहीं, बिकॉज व्हाई शुड द पेशेंट बी continuously remaining as smear positive and sputum positive, and deteriorating radiologically. So please, I would request the team to, have a look into the NICSHE reports, and then also look into the feedback needs to be given to the DTO, because this is one patient. I mean, we cannot let this happen to even a single patient, and this is one scenario which is in front of us.
Any other question?
Good afternoon, ma'am. I would like three practice recommendations from the experts. Firstly, is CBNAT recommended on follow-up or on completion of treatment, or do we assume that it identifies dead bacilli? Secondly, if the LPA showed INH and rifampicin sensitivity, then is it possible that the whole genome may still show resistance? And thirdly, what is the recommendation for MANTOs in contact screening?
Can you just say your questions one by one, because yeah.
Yes, ma'am. So firstly, is CBNAT recommended on follow-up or on recurrence, or do we assume that it identifies dead bacilli?
Would the host team like to answer?
Dr. Sangeeta, let me take this. So,
when we have Gigi, she's the best person to guide us over here.
So, doctors have a good question, but I think this is common knowledge that DNA has a long half-life. Hence, any test that picks DNA will pick live as well as dead bacteria. Hence, Gene Expert is not recommended as a follow-up. It can be a good diagnostic test, but not a good prognostic test. If we have a test based on picking messenger RNA, we can still, because it has a short half-life, and will get, obviously, if there are no live bacilli, no messenger RNA will be there. So we have done some work on messenger RNA for prognostication. It's available in the published domain long back, 2013 I've published that. The bottom line being, we are still looking forward to an mRNA based test which can help us with prognostication. A few tests are under development. Soon there'll be something. Your second question, probably, actually, I missed the whole case. There was another parallel meeting. But you also asked if the LPA could call it sensitive, whether NGS or whole genome could pick resistance. Yes, that is possible. Because the line probe assay has very few mutations. Number one, because of the practical feasibility of a nitrocellulose membrane carrying so many probes. Also, the sensitivity of the line probe assay is much less. Hence, the answer is yes, it's possible that additional mutations which are not represented on the LPA can be picked up in the whole genome sequencing. But if you ask me, and if you actually read up the literature in depth, phenotypic DST remains the gold standard for all drug resistance testing, primarily because mutations which have not been shown to have evidence of association with drug resistance may sometimes be misconstrued. So the bottom line, phenotypic DST, which is available in more than 100 labs across the country, culture DST labs, which are all external quality assured by the program, should have been done. And Dr. Sangeeta has already said culture was not done. I would prefer that we use the word culture DST rather than midget, because midget is a proprietary name. I think there was another question you said whether Montu can be that. I would say Dr. Sangeeta can take that question better for contact tracing. Dr. Sangeeta, over to you. I hope that answers your query, Doctor.
Ma'am,
Yes, ma'am.
I
Thank
just
you so
have
much.
I just have one question regarding in this case. They have done the CBNet, also done the LPA. In the LPA and CBNet, they found the sensitive. But in the next generation sequencing, there is rifampicin resistance, RPOB gene, INH, CAT, G mutation, all mutation is there, which was not caught in the CBNet and first line LPA. So I have one question: why these genes are not caught?
No, so let me cover this as well. Now, you see, again, this is some work that we have published, I think 2020. Heteroresistance is a mixture of strains. So basically, polyclonality is something which we have shown exists in drug-sensitive TB as well. By polyclonality, what we mean? It's a mixture of strains which infect a person. And there are some very good papers, if you look for in the published domain. The bottom line being, it is the treatment. So if you remember historically, we've read papers which said monotherapies will select resistance, right? So what monotherapies or inadequate therapies or poor prescriptions do is select out isolates which are resistant. That is why we put in so much effort to design combination regimens, whether it is DSTB, mono-H resistance, MDR-TB. A lot of energy and a lot of effort goes there. Now, when you say that it was missed in the initial samples, it could be accumulation of resistance while the patient was on treatment, for which, there can be 100 different reasons. Poor adherence, poor prescription, poor, compliance, or, other things as well. There are sometimes the drug absorptions do not happen properly. And again, a lot of TDM work also our group and Dr. Sangeeta's group, NIRT group have published. So the bottom line being, if it was missed at the baseline, Gene Expert has a very good sensitivity. LPA also doesn't have as good sensitivity as Gene Expert, but if that also missed, one possibility is that there was heteroresistance, which was below the limit of detection of Gene Expert's capability. And eventually, when the whole genome sequencing was done, possibly the number of resistant bacteria multiplied, or when the whole genome sequencing, like I said, I missed a few of the slides. If it was done from the culture isolate, whole genome sequencing usually needs more amount of DNA, is done from culture isolate, then possibly in the culture, the resistant bacteria amplified or were more predominant. These are the few explanations and truly scientific explanations. But what you also are trying to point out is whether we missed resistance in the initial samples, which again would be possible because like I said, the NAT tests also have several caveats. LPA has one, poor limit of detection. Two, there are losses between, because there are multi-steps involved. Then, though they claim they pick heteroresistance, but the number of bacteria required is close to 10 to the power 4, 10 to the power 5. So Smear negative samples, we sometimes get LPS positive, but not always. Very small percentage we get LPS positive. Extrapulmonary samples, similar example, similar problem, that we are not able to get LPA yields. I hope I'm able to satisfy your queries.
Thank you, ma'am, for this detailed explanation and clearing
What was the third question?
Montu for contact tracing.
Montus for contact tracing. Because the team did Montus and X-rays for all the contacts. So is that recommended or should it be done?
So the the Montu, the status is that Montu can be negative and still you can be infected depending upon your body. Montu is nothing but a hypersensitivity response. I may be hypersensitive to that antigen, the other person may not be. So that is the reason you have false negative Montu. There is a whole list of false negative Montu in which, it depends upon the stage of infection. Maybe that was in the initial phase, and then also the body's own immune response. If the context they are malnourished and they have a poor sensitivity, hypersensitivity did not develop, so the Montu can be negative. But negative Montu does not always rule out infection, remember that. But a positive Montu tells you that this is MTB infected. But now we have the other scenario which is also emerging, is what we call as asymptomatic TB. Please remember that. Dr. Urvashi has also published, even we published in IJTLD, in which, 7 children who were microbiologically confirmed. The context of, drug resistant pulmonary TB cases, they were followed up for 1 year, and 7 were microbiologically confirmed, out of which 5 were asymptomatic. So this is what is called as asymptomatic TB. So, we have to look at the whole picture. We have to look at the clinical symptoms. If the symptoms are there or not, then we have to even look at, the Montu positivity. But now we have the CYTB skin test, which is more specific than Montu because it just uses those 2 antigens, that is ISAT6 and CFP10, which are more specific for MTB complex. And
may I add to that?
Sorry?
I'd like to just add to that.
Yes, please.
So the question, I'm not able to say who was speaking anyway. Dr. Savia, question was whether for screening we recommend Montu. So for screening, the WHO publications give, X-ray has 94% sensitivity to pick TB. If we compare X-ray and NAT for screening, I'm not talking diagnosis. For screening, X-ray amongst the tools available till we have omics tool, proteomics, metabolomics, and other tools which are developed which can pick up early TB. X-ray is able to pick up both subclinical and clinical TB. You're aware of the 4 stages: latent, incipient, subclinical, and active TB. So subclinical is from TB, where the patient will have a lesion in the lung, will continue to infect others, but himself remains asymptomatic. The idea behind our new strategy, where our active case finding strategy went on under the program to offer X-ray screening to our vulnerable populations. So the vulnerable population we picked from our National TB Prevalence Survey data as well as our NICSHARE data, where 80% of TB patients were amongst the vulnerable groups. Again, this is by now, I started this whole new strategy when I joined as DDG, and now it is common knowledge. Everybody knows asymptomatic TB, vulnerable population. So coming back to your question, when we want to screen the family, X-ray is mandatory, but along with the X-ray, we have to have clinical examination. And Montu, if the team used, they may have used, because in children, sometimes when other things do not come in handy, Montu, which is a signature of the immune response, the cell-mediated immune response, CMI of the patient, it can sometimes corroborate as evidence of disease. So this in children can corroborate disease diagnosis, but for screening, we recommend X-ray. I think that was precisely what you were asking, and what Dr. Sangeeta talked about asymptomatic TB. I'll just quickly finish in one sentence that this new strategy that I rolled out of diagnosing asymptomatic TB has yielded our active case finding efforts has yielded more than 9 lakh asymptomatic TB since we launched the TB Mukt Bharat Abhiyan on 7 December 2024. I think the numbers may have in fact crossed 10 lakh, which is contributing to our total burden. The bottom line being these patients would have been missed if we had not gone looking for them using an X-ray screening. And the program has now expanded the handled X-ray capacity in the country. Today I can talk of more than 3,000 handled X-rays. Will soon be available. Recently, we procured more than 1,500 handled X-rays, and we already had 500. More are coming as we speak. So at each of our Ayushman Arogya Mandirs, from our CHCs, we can send vehicles to do camps to screen vulnerable groups and diagnose using a NAT, which again our capacity is more than 10,000 NATs today. So that is how the program is progressing. I hope your queries have been answered. Thank you.
Thank you, ma'am. I think we'll now progress with the discussion. Dr. Satya, you can continue with your case.
One question has been asked where they're asking, can CyTB be used in children? So the use of CyTB in children, the program is not yet recommended. We are having the National Technical Expert Group meeting on 26th. We will deliberate on this, and once the program approves, this can be used in children. As of now, we have not yet recommended.
Thank you, ma'am, for clearing the air. Dr. Satya, you can continue with your discussion now.
Yes, ma'am. Am I audible?
Sorry, there are a few more questions. Can I deal with those? Like one question asks for any role of TB Gold test. So TB Gold test is nothing but another cell-mediated immune response detection test, same as MON2, same as CyTB. It is very expensive, and we have written to the DCGI because the kit insert in the TB Gold test says it can be used for TB diagnosis, which is a false statement. We have already objected to that statement, and we are hoping that the company will change that. It is only to detect TB infection. So all of us who know the relevance of MON2s, all the three, whether it's MON2, CyTB or IGRA or TB Gold, do the same thing. They look for interferon gamma response in response to an antigen challenge, whether it is done in vitro, in quantiferon and TB Gold, or in vivo actually. So in vitro was the wrong term. It should be called ex vivo because the cells are live. You stimulate with an antigen and you see the release of interferon gamma in IGRA and TB Gold, while in MON2 and in the CyTB, we inject an antigen intradermally, look for the cell-mediated immune response, which, like Dr. Sangeeta had said, could be negative due to energy. And there are papers, I can think of a paper from Korea, which clearly showed during TB disease also, the IGRA, the TST could be negative, and hence TST, CyTB, IGRAs are not to be relied for diagnosis of TB disease. It can only pick up CMI. Again, the sensitivity of all these tests is less than 60%. So it will not pick up all patients with infection. Thank you.
Thank you, ma'am. Dr. Satya, over to you now.
Yes, ma'am. Just wanted to clarify a few details before I go ahead, ma'am. We did do an extensive background search using the patient's NICSHA IDs and looked at all the investigations that were available. And she had 4 NICSHA IDs actually, and we had gone through all of them, and we found only one second episode when she had only one LPA report was available. We did not get any reports of any cultures or phenotypic drug sensitivity testing reports are not available. So moving forward with the discussion, so we'll be seeing MTB next generation sequencing and drug resistant tuberculosis. So recurrent tuberculosis is a diagnosis of subsequent episode of tuberculosis following either treatment completion or cure at the end of the most recent course of treatment. And this recurrence can be either a TB relapse or a TB infection. The TB relapse is the subsequent episodes but the strain is the same strain as the initial infection. And it's also known as endogenous recurrence, and it is due to reactivation, reemergence of the original infecting strain. As for TB reinfection, it is subsequent episode due to a strain which is distinct from the original infection. It's called exogenous reinfection. To make the distinction between TB relapse and TB reinfection, we need a genotyping evaluation. So the term recurrent tuberculosis is currently used clinically. So what happens is the patient is exposed to MTB, and then he started on treatment after identifying the infection, and then he completes treatment and there is a cure. And post-cure, you can have infection of the same strain, which is called relapse, or with a new strain, which is called a reinfection. So what are the risk factors for recurrence? It can be agent, host, or environment factors. And agent factors are if the strain itself is drug-resistant strain or there's high bacillary burden, like a cavity disease. Host factors include either primary or acquired immunodeficiency or any other immunodeficiency states, or the child is very young age due to an immature immune response, which can cause dissemination and reactivation of the original infection. And environmental risk factors, if there is continued exposure with the infectious adult, or if there are other social settings like overcrowding, poor ventilation, high community TB burden, and lack of proper contact tracing and household contact preferences, these all can cause risk factors for recurrence. However, before labeling recurrence, we should look into the previous regimen, inadequate initial regimen and treatment duration, if there is poor adherence or any comorbidities like poor absorption due to vomiting, malabsorption. These all can cause poor response to treatment. And also, finally, poor drug penetration and variable drug pharmacokinetics can also cause poor response to ADT. So, the prevalence of recurrent TB in India this is a study done from 2019 to 2021, which showed that out of 3.2 lakh individuals who were screened, 1,402 were having TB, and out of this, 27% had recurrent TB, and out of this 27%, the proportion of drug-resistant TB was 11.3%, and in the new patients who had drug-resistant TB was 3.6. So that itself is a risk factor for drug-resistant TB. There was another study which recently published in this year, which showed that in children recurrent TB, the recurrence rate post-treatment was around 7.9%. There's more in children in the urban slum, in urban areas, and risk factor was children with failure to gain weight had a high recurrence rate. So as per programmatic data, WHO Global TB report, it showed that the estimated proportion of new TB cases with MDR resistance TB was 2.5%, and in those with previously treated TB cases, the proportion is high at 13%. And similarly, as per the NTP Pediatric guideline 2022, the prevalence of MDR TB in previously treated patients was 14%. So what are the methods to test for drug resistance? It can be either phenotypic drug sensitivity testing or genotypic resistance testing. Phenotypic testing, the actual growth is observed in the presence of defined drug concentrations. If the bacilli grows, then it is called, despite a critical drug concentration, it is called resistant. If there is no growth, it is called susceptible. The disadvantage is a very slow process. Turnaround time is 1 to 8 weeks, and there is need for culture. However, in genotypic resistance testing, the presence of mutations is seen using techniques like PCR in tests like NAT or whole genome sequencing, and then resistance is confirmed and compared with an existing catalog of validated mutations, and then the patient is labeled as resistant. This process is rapid, from 2 hours in expert to 1 to 2 days in LPA and few days for generation sequencing. And sometimes some of these specimen tests can be done directly on clinical specimens, and that can avoid a culture. So under genotypic resistance detection, we have multiple tests: NAT, line probe assay, and expert MDR-TB. However, most of these tests detect only they target hotspot regions of a few genes, and they can detect resistance only if there is mutation in those few genes only. So they detect resistance to a restricted number of drugs. So what is next generation sequencing? It is a method used to determine the nucleotide sequence of a whole genome, and typically uses non-Sanger based sequencing technologies. So what is done here is multiple DNA fragments in parallel are sequenced and then pieced together. A reference genome is formed, and this compared to the reference genome using bioinformatics analysts to see if there are any mutations in the index DNA. So the workflow is usually sample is collected, and then culture is done, and DNA is extracted and done into sequencing. It's compared with a known catalog, and then the report is generated. So types of NGS, this sequencing can be done either in whole genome where all the genes and even non-coding DNA are sequenced. This has long turnaround time and accuracy is low and is also very expensive. Or exomes, the whole exome can be done where only the entire exome, the coding part of DNA can be done. Or a certain targeted gene panel can be taken which is known to have resistance and that has a higher accuracy and rapid turnover time. So difference between targeted next generation sequencing and whole genome sequencing is that whole genome sequencing has a step of culture where it takes around 7 to 15 days, and targeted genome sequencing is more rapid. You can bypass the culture step. It can directly work on sputum and other samples and turnaround time is 12 to 48 hours from sample to result, and also has a lower cost. So the use of NGS in TB, it can be used for surveillance of strains. It can be used to identify what strain and what species is isolated. And like already discussed, it can be used to look for presence of multiple isolates and heteroresistance. It can also be used to see drug resistance, rapid detection of resistance, and so individualized treatment can be started. And in epidemiology, it can be used to detect transmission patterns in outbreaks. So what is the evidence for whole genome sequencing? This was a systematic review done in 2017, which looked at the sensitivity and specificity of whole genome sequencing to pick up resistance, and it showed good sensitivity and specificity for both rifampicin and INH. This was another study done where comparing next generation sequencing to phenotypic drug sensitive testing, and it showed that NGS provided faster turnaround time than phenotyping testing with a median of 3 days compared to median of 21 days for uh, phenotypic testing. And the agreement between NGS and existing assays were excellent for isoniazid, rifampicin, and second-line drugs, and also good for other drugs. There was another study done published in 2023 where they compared 3 different methods: phenotypic drug sensitivity testing along with LPA and targeted next generation sequencing, and the results showed that the resistance frequency detected was similar across all the methods. So in 2024, there was a systematic review and meta-analysis which was published where they predominantly compared targeted NGS with phenotypic DST, and it showed combined sensitivity across all drugs was very high, and even for specific drugs also, NGS was diagnostic accuracy was very good on both clinical samples and culture isolates. This was a recent study just published in November of 2025, where the authors tried to see the role of next generation sequencing and see if it can be implemented in a programmatic or an algorithm regimen. And they showed that while targeted next generation sequencing provided complete resistance data for 73 to 86%, phenotypic DST achieved better results, showing around 92 to 93%. However, both these tests exceeded the sensitivity of WHO recommended molecular assays. So they gave an algorithm which stating that after initial testing is done with NAT, further testing can be, if there is resistance detected in the first test, further testing can be done using targeted next generation sequencing to detect early resistance to other drugs, and then eventually which can help in the formation of a individualized treatment program. Despite all the advantages, there are a few cons to next generation sequencing. There is a limited availability of tests, and it's a high cost of tests and infrastructure which is required for setting up these tests. Need a specialized lab. Whole genome sequencing is predominantly culture dependent. There's a long turnover time, and there's a risk of missing mixed populations and heteroresistance. Targeted next generation sequencing in pediatrics, there is a paucibacillary disease of tuberculosis, so direct sample might not always yield results if there is no growth or AFB is not picked up. It can also be contaminated with host DNA, and sometimes resistance patterns can be missed. And it covers only predefined genes resistance regions. So resistance for certain drugs like beta-quilin and linezolid might not be picked up. The most importantly, the knowledge gaps are high, and this is an evolving mutation catalog, and new novel mutations which might be picked up as per next generation sequencing will always need a phenotypic DST backup to see if it is clinically relevant. So programmatic implementation of these tests might be challenging. So coming to what the WHO recommends on NGS, there are 2 recommendations. First recommendation is that targeted NGS may be used on respiratory samples to diagnose resistance to rifampicin, isoniazid, fluoroquinolones, pyrazinamide, and ethambutol, rather than culture-based phenotypic drug susceptibility testing. And WHO also says that this patients who should be given high priority are those with higher risk of resistance to first-line treatment, and like in our case, those with either treatment failure or history of previously had TB treatment. Second recommendation is that in people with bacteriologically confirmed rifampicin resistance, pulmonary TB disease, targeted NGS may be used on respiratory samples to diagnose other drug resistance, and with similar priority given to people with higher risk of resistance. So to conclude, MTB next generation sequencing has revolutionized TB management because it does enable rapid drug sensitivity testing to both first and second line drugs directly from sputum, and we might not need even culture based methods for certain.
Dr. Satya, are you still online? Dr. Satya?
And bioinformatics labs and expertise is required, so it might limit programmatic use. Thank you.
Thank you, Dr. Satya. This was indeed a very well worked up case, and you were able to pick up resistance in this case, a case which had been receiving multiple courses of drug resistant TB. So thank you to AIIMS Jodhpur team for this interesting case, which had multiple learning points. So the case highlights the importance of documenting the child's clinical, microbiological, and radiological improvement at the end of treatment as is recommended in the program. And also, if we are dealing with cases who are not responding, these such cases should be evaluated in depth, checking the compliance of the drugs, the drug dosages, whether they are adequate or not as per the weight band, whether the patient is getting the drugs adequately or not. And we can also consider getting therapeutic drug levels if some metabolic illnesses may be causing subtherapeutic levels, which may be a reason for not response in such patients. And of course, we also need to go all out. If we have checked all these factors, we need to go all out in such patients to rule out drug resistance as well. So thank you, AIIMS Jodhpur, for this interesting learning session today. And our next TB Eco Clinic is scheduled for 3rd Tuesday of January, where we will meet you all again for an interesting case discussion, which will help us enhance our knowledge and also help us to manage our patients better.
So I'd just like to add, for our DRTB patients, we've already rolled out the targeted NGS, which is happening in our centers of excellence. And soon we'll scale it up to take it to other culture DSC laboratories so that it can come as, as a report. It can be utilized for the sake of the patient. And of course, for culture DSC, we have enabled more than our 43 labs have been trained even to carry out predominant and vernacular DST, in addition to linezolid moxifloxacin, which was being done earlier. So the BPAL-M, we're trying to push at least in more than 14 years age group. As soon as we have a good regimen in less than 14-year age group for our DRTB population, we'll bring it on board. Thank you so much.
Thank you, ma'am.
Anyone ask?
Any other questions? I think Dr. Mamta has some questions.
Yes.
Ma'am, I had posted this question on the chat box. I think it was missed. Many a times there are cases which are very low and low detected by the CBNAT, and such samples when sent for LPA, since they are low bacillary load, the smear will be negative and they will be put up for culture. Culture usually turns out to be negative. So LPA is unable to be done on such samples. So any recommendations to deal with such cases where gene expert or the CBNAT has detected?
The guideline, so this is a very good question and helps me reiterate the guidelines. The guidelines is very clear. You see, the science behind whether it's gene expert or the LPA is that the probe is binding to the mutated site, the mutation. When the number of bacteria is less, the DNA amount is less, the binding may not happen, and the absence of binding is then misconstrued as resistance. I hope I've made myself clear. Hence, in low and very low, the guidance both from the National TB Elimination Program guidelines, request to mute please, both the NTEP guidelines as well as the WHO guidelines clearly suggest not to conclude resistance based on low and very low reports. In case the report is low or very low, ask for a fresh sample. Shashikant, please mute. So, in low and very low samples, you are expected to ask for a repeat sample. And as rightly pointed out by Dr. Mamta, the LPA will also miss. Hence, these patients may be DSTB, more likely to be DSTB, will be offered drug-resistant TB treatment, which is incorrect. Always go for a fresh sample and repeat the test. Does that answer your question, Dr. Mamta?
Yes, ma'am, but what if these are extra pulmonary samples which cannot be collected again?
So
Most
in
of our
that case,
samples.
yeah, in that case, the only savior for us is culture. And culture yield, there was another question I think I was not able to address earlier. Culture yield in well-collected samples is more than 40-50%, 40% at least for extrapulmonary as well. In CSF samples also, if the culture is put in expedited manner on the same day, we get more than 25-30% yield. So that can be helpful, but there is no other way to do it. We cannot go by drug resistance, which is picked in low or very low gene expert detection samples, because that can be a misguiding result.
I can just add over here for your answer. You have to see the clinical profile of the patient, whether it's a new patient, whether there is any history of contact with DRTB, if or there has been a death in the family, or the child is seropositive. If none of these risk factors is there, then it is worthwhile just start the DSTB treatment and wait for the response. Within 1 month, you will come to know whether it is DSTB or DRTB. Because as Dr. Urvashi has said, the guidelines are very clear. Whenever it is a trace or very low, then you have to take it as resistance is not to be considered. You have to take it as drug sensitive and start the treatment accordingly. But for a retreatment case or a failure case, then obviously the scenario changes. In that case, you are justified to label it as probable MDR and start MDR TB treatment. So the treatment is individualized depending upon the case scenario. New patient, no risk factors, start with DSTB treatment and wait for the response. Reevaluate at 1 month. If your child is not improving, patient not improving, it could be probable MDR, and by that time the liquid culture report, the DST, may become available. And if it is a retreatment case or a failure case, then in such a scenario, look at all the clinical parameters and label it as probable MDR and start the DRTP treatment.
So, not that we are not supposed to rely on gene expert, but only in the case of low, very low. I don't talk about trace because trace, as it is in an endemic country, cannot be relied on. Resistance detection in low, very low samples is to be taken with a pinch of salt. You always must reconfirm it. Start DSTB treatment, and then you can ask for a repeat because you detected it. If it is drug resistant, only in low, very low, you repeat. So that is the message. And of course, the clinical picture. Clinical picture is very important, even in like the case that was being discussed. Clinical examination is mandatory to call a patient cured. Just treatment completion is not equivalent to cure. Clinical examination, X-ray examination, culture of the sample. All three have to be done when you want to say the patient is cured after treatment completion. If that is not done, then we may face more such cases. So these are very, very important things. And like I mentioned, TDM work, therapeutic drug monitoring work, has been published by several good institutes, several top institutes in the country. And we know that even patients who are drug sensitive TB sometimes may not be able to absorb all drugs. Pediatric studies have been done by Dr. Sangeeta's group, AIMS pediatric groups, AIMS Delhi's pediatric group, and we have found several children who do not get to absorb all the drugs. So in case of non-response, we can always try to assess the drug levels and revise the drug dosages also. Also, whether when the child gains weight during treatment, in case we want to enhance the, as the drug dosage per body weight, that aspect also I would just, highlight if Dr. Sangeeta can mention that drugs have to be per kg body weight. So those issues, as a child gains weight during treatment, 2 months on the treatment, if we want to modify the dosages slightly, that should be done. Thank you.
Thank you, ma'am. With this, we come to the end of this 20th TB Pediatric Eco Clinic. And before I wrap up, I would like to thank AIIMS Jodhpur team once again. And we all will meet again on 3rd Tuesday of January with the next interesting case. See you in January.
Thank you, everyone.
Thank you.